Today I welcome Dr. Julian Somers, a clinical psychologist whose work focuses on addressing harm reduction and recovery from addiction. Julian is a distinguished professor from SFU and the director of the Center of Applied Research in Mental Health and Addiction. In 1987, Dr. Somers began his work supporting people with severe forms of addiction and mental illness at Coquitlam's Riverview Hospital. Prior to his current roles, Julian was director of the psychology clinic at UBC and once acted as the president of the BC Psychological Association. He has led large studies investigating ways to improve clinical practices and policies related to addiction and mental health. Today, we will be discussing the reality of addiction and homelessness in Vancouver and in comparison to other cities around the world. Then we'll dig into government policies that have and have not worked. Julian, thanks for coming on to Coastal Front today.
It's great to be with you, Andrew.
Yeah. Just to preface this for our listeners, we're going to cover four topics of crime, homelessness, addiction, and mental health. And one of the things that you've really like to point out to listeners and people who are coining on your conversations is they're all tied together.
Yeah. For a number of years working in this space in BC, so I really started working with governments around the late 1990s, including the BC government, other provincial governments, and since then I've worked outside of Canada. But over the years in BC in particular, we've had policy sort of thrusts, reactions that focus on one of those things. So we've got, tent cities. What are we going to do about that? We've got random acts of violence or occasionally violent acts that appear to implicate people with mental illness. What are we going to do about that? And we have addiction. Now, of course, we have a poisoning crisis. And it's been the tendency of most governments, actually including the current one, to try to treat these problems as though you could attack one of those strands on its own.
Like in isolation,
in isolation, mm-hmm. Yeah. So we have task forces, or we have in the current instance, we've got to focus on trying somehow to make a difference by focusing on the supply of drugs, manipulate that. But places that have been successful have recognized what I think a great many British Columbians recognize, which is that they're not separate and they're all connected. And people like me and others who work in this space have been saying that for a long time. But we're finally, I think, at a point where we can't deprioritize this set of issues in favor of other things that are urgent. There are always too many things for us to address, right? So I'm not saying this saying, finally, where's everybody been? I understand that there's competition for addressing public priorities, but this one won't be solved until we all recognize, and especially our leaders recognize, the interconnections.
When we look at British Columbia and we talk about these four topics, crime, addiction, mental health, and homelessness, there's nothing that epitomizes that environment more than the downtown Eastside. Now, most of our listeners are from Metro Vancouver, and I'm sure many of them have at some point driven through the downtown Eastside. I happened to drive through there recently and was amazed at how much it changed even from the last time I drove down there, which was maybe about a year and a half ago. The amount of tents and just like open demise of these, maybe that's not the right word, but just suffering. I think that's a great word, a suffering of these people down the downtown Eastside. For those people who haven't been down there or haven't been down there recently, Julian, can you kind of paint a picture for the listeners as to what the downtown Eastside looks like today?
I'll try. Let me start by saying that the people that are living in that state of suffering that you described, I agree, that's a good summary. Almost all of them moved into the metro area from somewhere else. So in some of our work, we made contact with the 500 people that by service providers, this is police, outreach workers, first responders, deemed to be the, air quotes, hardest to house, the people who were least likely to get assistance from current services and the people who needed help the most. So we found our way over about a year to 500 people that met those criteria, and we asked them for their consent to access records from the province. So records, British Columbians have to register each year for our medical care cards. As part of that, we have to say where we're living. So we asked our clients for information about a wide range of health-related service involvements, justice involvements, when they needed shelter support or other emergency financial assistance. And we got those records going back about 15 years. So in some of our publications, we show that 10 years back, 85% of them were not in Metro, and they slowly move in. And the reason I start here is that when we begin sort of characterizing how people are living and answering your question a bit more directly, what's going on in their lives, we need to consider that meaningful solutions are not going to be implemented in Vancouver. Okay. Meaningful solutions are going to be ones that help prevent this migration process that people experience. They're already beginning to move. They're already homeless when they're beginning to move from wherever they were. Oh,
is that right? Okay.
Yeah. And we see that,
so it's not like they show up in the downtown Eastside in good shape and then it just goes down from there. They've already been on a path of misery and homelessness or whatever, mental health, without treatment, as they make their way into the downtown Eastside.
That's right. So you can think about sort of the proverbial vicious cycle, and in this case, the vicious cycle of people that we've worked with in many studies and projects over the years involves life on the streets or life in grossly substandard housing that is visibly unsafe socially and unsafe physically, and involvement in crime. Among people, one of our studies looked at 14,500 people all diagnosed with opiate use disorder, so opiate addiction. And they had on average 5 convictions per person, so 70,000 for the group. And of that number, 3.8% of their convictions involved the offense of possession. When that particular offense showed up, it was almost bundled with a more serious offense. And more than 50% involved theft. Now, I'm going to theft because they need to steal things to survive. So there are people living in squalor, unemployed, with serious addictions and mental illnesses that are almost entirely untreated.
Right.
So this is the group that winds up in the downtown
naturally
Eastside.
They're going to be driven towards criminal activity like theft.
It's either steal something to eat it or steal something to sell it so you can buy drugs, or wither away and die right now. And about 10% of their offenses, so still a vastly greater number than those that involve possession, are violent offenses because of the conditions they're living in, the people they're living around, and the chaos of their own psychological experiences.
Right.
So they're starting off in other parts of BC, a few outside the province, but mostly around BC, where there are no resources and very little capacity to support people, and a lot of places that are also colder than here on the coast. So they move and they wind up not initiating this vicious cycle, but it accelerates. So we've published what happens year over year from the time people begin encountering hospitals, jail, the streets, wherever they're starting off, and then what happens over time as they find their way into neighborhoods like the downtown Eastside. And all those metrics go up year over year over year. It's just a steady, relentless increase in evidence of hardships, evidence of crises associated with suffering. The cost of this, there's so much research that's been done by now. There have been several costing analyses. It's about $55,000 per person per year for British Columbians to support people living in this type of squalor and despair. We've done randomized controlled trials.
It's a huge cost.
Massive. I mean, it is literally and demonstrably true that we could start helping by choosing the people who currently cost, say, above $100,000 a year, and provide them with housing and support, knowing from randomized trials that it's going to markedly improve their lives, but it's also going to cost taxpayers a lot less. And we are not doing that. In fact, we're not even willing to have a conversation about that in BC. That's where we are.
Wow. Well, we're going to get into that. Just to help understand whether Vancouver is unique or it's one of many other cities, in your travels and your research, if I was to go to Calgary, Toronto, Montreal, or some of the major cities in other parts of the United States, would I see the same thing? Is there a downtown Eastside equivalent in some of these other cities, or is it particularly worse here in Vancouver?
If we look at BC, it's not only particularly bad in the downtown east side historically, central Surrey and other places, but the same sort of pattern of a street entrenched community living in despair, marked by odd behavior that looks like mental illness, as well as visible drug use. That's becoming increasingly prevalent in many BC communities. Nanaimo has been in the news the last few days. It happens to be the riding of our Minister for Mental Health and Addiction. But the complaints from citizens are very much along the lines of the concerns of people in the downtown east side, looking at safety, not only their own safety, the quality of the neighborhood, but the safety of the individuals. Like surely we can be doing better for people, right?
Yeah.
And that's where they are. So it's spreading in BC. It's generally, if we go east to west in North America, a West Coast phenomenon. The West Coast cities. So we hear about
San Francisco,
Portland, San Diego, LA.
Is this climate driven? Is that what it is? I mean, just a more temperate climate. Is that political? I mean, we're kind of on the hippie left coast here, right? A lot more left leaning progressive, so-called progressive, than in the conservative center of the. What are we talking about here?
Well, I think there's merit to both of those things. So weather and climate, a very left-leaning population, but I think also, and it's hard to quantify how much of these things are contributing to the difference. There are clear differences, though, if we look East Coast, West Coast, very clear differences. But another one that is also potentially relevant, East Coast, West Coast, is that here in BC. Even unlike other places across the prairies and in Eastern Canada, many of us have very shallow cultural roots. We come from maybe 1-2 generations back. We are a very eclectic group, and we have very few shared traditions. We don't even root for the same hockey team necessarily, right? Yeah.
Or if we root for a hockey team at all.
Or that, exactly, right? So now, of course, all these comments are accepting Indigenous people whose culture is rooted in time immemorial.
Yeah.
But for all the rest of us, we have very little culturally that binds us together, and culture winds up being, and cultural practices wind up being huge protective factors in relation to addiction and even homelessness. Cultures of caring, cultures of looking out for one another, and something else that goes with that is membership in groups.
Okay.
So if you go to the East Coast,
I guess what you're implying is this sort of sense of community.
That's right.
I mean, if you looked at a culture like Japan, it's probably very different because there's not a lot of immigration into Japan, and they're a very homogeneous kind of society. Is that a fair comment? Absolutely.
Japan is miraculous in having essentially no homelessness.
Yeah, that's true. I mean, you go to Tokyo, it's amazing.
So there is this. Now, there are other downsides to that, other pressures on citizens, but I think what you're referring to is a different kind of social contract. There are expectations in society related to the performance of individuals. We as individuals have responsibilities, but society has responsibility to us as well. If we observe those responsibilities, we ought not ever to be in a predicament of abject poverty and homelessness. There should be a place for us. Mm-hmm. And many countries around the world do that better, a lot better than we do.
Well, this is good. This helps to paint a picture for how bad it is, and maybe some of the reasons why it's developed the way it has. My understanding is that in Portugal, they had a national drug policy that they implemented in 1999. I think you've spoken about this before. And they stated that there was no such thing as treatment without social reintegration. Can you take a moment to talk about, first of all, explain to the listeners what happened in Portugal in 1999? Because while it's maybe to a certain extent a bit of a homogeneous, I mean, I've been to Portugal, it's a bit of a homogeneous, society. It is a center point for a lot of migration and immigration between Africa and other parts of Europe. So maybe you can talk for a minute about what happened in 1999 and the success they had and the turnaround they had there.
Yeah, thanks. It is a remarkable story, and it has some lessons for us in BC and actually Canada that we can be inspired by and maybe emulate. But we're going to have to do it in our own way. They had in the mid 90s already the worst poisoning epidemic in Europe. The visible drug scene along the lines of what we were discussing a few minutes ago in almost every Portuguese town and city, and just this incredible epidemic of drug use and deaths. So they before they launched wrote their national strategy, they had a fairly intensive period of consensus building. This was consensus building around what Portuguese people were opposed to. But more important than that, it was, what are Portuguese people for? What are we for? And as the quote that you read a moment ago is I think a powerful illustration of that. We are for people being integrated in communities.
Right.
So how do you do that? Well, one of the elements of their approach, which already differs sharply from what we're doing in Canada, their national strategy is a national strategy for the fight against drugs. It sounds like war on drugs.
Yeah.
And they mean it. They're saying, number one, this is a prevention strategy. We're doing this because of a crisis, but our vision is prevention. We don't want our youth to be using drugs. We don't want, and this includes cannabis, by the way.
Right.
We don't want our youth, to be prone to developing problems. We need to support our youth in their development. But for people who currently have problems, we have a crisis. So how do we apply that ethos of providing supports for people? And I'm back to a social contract, because this is coming from the Portuguese society writ large, including its institutions. What vision do we have for people, and how are we going to address this crisis and get closer to our vision? Yeah. So they notably decriminalized the possession of drugs in Portugal, as in Canada and many cities here. Possession of drugs was not a widely prosecuted offense prior to the national strategy. It is incorrect that decriminalization is a centerpiece of the Portuguese strategy in terms of contributing to changes. In fact, by making possession an administrative offense, it gave police greater opportunity to become involved in the lives of in the physical space and in the lives of people that they saw using drugs in the open air. And they used this administrative sanction to take people to what are known as dissuasion commissions. The Dissuasion Commission is an interface between the police and an array of resources that they are not directly attached to. So it has a degree of independence that affords the freedom to make referral decisions without self-interest. We're not referring people to our program, and so for people who have been the hardest challenge, the greatest challenge, I should say, not the hardest, the greatest challenge is for people who not only have drug problems, are homeless, are unemployed, but who have no social network. They don't have a family or other source of social supports to aid them.
They're truly on their own.
They're truly on their own. They also, and now I'll refer to things that we've learned about folks in BC, they also tend to have had what we call adverse childhood experiences, just really very arduous and often painful experiences of development throughout their whole lives. Nobody's told them on a consistent basis that you're lovable, you're worth things, you can do things, given choices about things that matter. Very little of that. So what do you do with people who have that kind of syndrome that they're experiencing? And one major answer is known as therapeutic communities. So these are places where people can be referred to and can go for up to a couple of years or longer. typically, and by the way, we're talking about people who are generally young people. So in our work, the average age is in the mid 30s, but we see people from teen years up, and so people who have decades ahead of them, people who overwhelmingly, if you ask them day one, so there they are, you're talking to them on the sidewalk, asking about priorities, and 85% say they want to resume paid work.
Wow.
Right? Seems like a long journey from that point.
Yeah, sure.
But they'll tell you that.
Well, that's your goal.
And so therapeutic communities incorporate vocational training. And Portugal had 64. I don't know if they still have that number, but 64 of them, where people could be referred, and some would be oriented toward men, women, some mixed. They'd focus on different aspects of vocational training. They'd each have different cultures, and people ought to be able to choose when you have that sort of an array. They ought to be able to make a choice. So this is a huge part of what contributed to their success. The fact that they did that meant that they did not need a single consumption site, drug consumption site, in all of Portugal. Now, this is not a diss on consumption sites. Consumption sites are one way of reducing harm, but they're not simply a way of reducing drug consumption-related harm. They're more specific than that. They're ways of reducing harm when you have a population of drug users that's homeless. That's when you really need consumption sites.
Right.
If you are committed to addressing the harm of homelessness independently by providing therapeutic communities or other community-based living for people, then you don't need consumption sites, not because they're a bad idea, but because you're addressing the harm of homelessness in a different way. And that was their decision.
Can you talk to the numbers? Like, how did things change so that we can put some real context to this?
Well, they went from having the highest rate of poisonings in Europe to the lowest over about 6 years. And along
today,
the way,
I mean, that was 1999, so that takes you to 2005. Do you know what the status is in Portugal today?
My Portuguese friends, if they listen to this, they won't like this, but they need to do a better job of record keeping. They really have not done the greatest job. They've and honestly, the people driving this have not. They were not concerned about showing things to the world. They were concerned about showing things to people living in Portugal and for their own society. So many of these stats are I've been told, and this is by colleagues working in Portugal, that after the financial crisis, the things started to become strained for them as well as for many providing public services, and they saw an increase in street drug use. In 2018, I believe it is, they implemented their first mobile consumption site, which was a recognition that the resources that they had previously were no longer sufficient to meet demand. But the most recent stats I've seen, their rates of poisoning are still among the lowest in Europe. Something that has been reported more that's relevant is drug seizures are very high in Portugal, related to being a coastal country and a gateway.
So what's
to
a
Europe.
drug seizure?
Oh, seizures of drugs like cocaine, fentanyl.
Oh, I
heroin.
see. I'm sorry.
Yeah.
I thought you meant like a seizure in your brain.
Oh, I beg your pardon.
Yeah. Okay.
No. So
intercepting.
the focus
law
on trafficking.
enforcement.
Yeah. They remain very aggressive on that front.
I mean, to me, that's what would tie a big tie between Portugal and British Columbia is it'd be like multiple ports in which you can traffic drugs. I'm sure they have the same problem that we're experiencing here in BC.
If it was that simple, then why not Japan?
Yeah.
Right.
Yeah,
why not England?
Yeah.
Why not? So it's this is something we've been. I think it's been overemphasized to us by our leaders that that the problem has been summed up for us as a toxic drug crisis. That's what we've been told.
Yeah.
And people like me, so I mean, academic types, and we focus on these words because this is government's telling us what the cause is. And once we hear what the cause is, and it makes sense to do something that's somehow related to the cause. So but this statement of cause, that the cause is toxic drugs, is simply wrong. It is wrong, and it is useless. It does not afford us any opportunity at all to make progress. If we've learned one thing from the, what is it now, 60 years of the war on drugs, no, 50 years of the war on drugs, it is that we cannot substantially reduce problems of addiction by trying to intervene in the supply of drugs. All the current government is doing is rebranding the war on drugs. They're saying, no, we're not going to focus on the supply by trying to intervene with the narcos. We're going to try and make a difference by displacing them. We're going to become the dealers, right? Pharmaceutical supply. Yeah. But it's still the same old, same old. It's a supply focused analysis. And it's not even correct because the supply is people who are dying. An Alberta coroner's report recently reiterated this. Over 90% have multiple illicit drugs in their systems. So if someone's dead and you find that they started out drinking, then they consumed some fentanyl, then they consumed some cocaine. The bump of cocaine caused them to take more fentanyl. Now they're dead. Which drug killed them?
Right.
Which one is it? Yeah. How do we get to? It's a fentanyl crisis.
Yeah.
So supply is useless. We need to focus on demand. What are the conditions in our communities that are causing people to demand drugs in that way? And that goes a long way down the track to helping us, because even in these coastal countries where there are prevalent addictions and consequences like poisonings, there are still lots and lots and lots of people who live in those communities who are not at all interested in participating in using drugs addictively or putting their life in jeopardy.
Yeah.
What's different about them?
Yeah.
Typically, they have lives that to them are inherently more meaningful than using drugs.
So, Julian, if I can just summarize this in layman's terms, it sounds like what you're proposing is policymakers, leaders in our government need to move away from a focus on the supply aspect of these illicit drugs to why is there demand in the first place? Is that as simple as that?
Yeah.
So you don't actually, so this idea, because I have always had the view that the reason we lost the war on drugs is because we stopped fighting it years ago. Like we just kind of opened up the borders. We've literally legalized cannabis. Now, I don't know if it was a fallacy or not, but when I was growing up as a kid in the 1970s and 80s, I was constantly told that don't do any drugs because like things like, marijuana is a soft drug and it's a gateway to hard drugs. What's your opinion on that, by the way?
The gateway hypothesis has not been well borne out.
Okay. So you don't believe in that. And so it sounds to me like what you're suggesting is like whether we have cannabis legal or illegal, that's not the issue. The issue here is what's causing people to want to take in these toxic, cannabis is not a toxic drug. People aren't dying. Although I still think there's some issues around cannabis because I have some people I know really close in my life that are seem to be addicted to it. We could probably go on a tangent on that. But
no, that's absolutely that is verifiably the case.
Yeah, but there's also people addicted to alcohol. It's like a major industry. Yeah, way more. Okay, well let me just pivot for a moment because I want to talk about some. I'm a big guy on numbers and stats, and these tables we have in front of us here are quite fascinating. So these are from the BC Coroner's Service, and one of them that shows us is the percent of illicit drug deaths by fentanyl. And in 2000, just to give some context, in 2012, fentanyl deaths accounted for 4% of all the deaths by illicit drugs. 4%. And then it went from 4% to 15 to 25, 29. And then there's a huge jump in 2016. It went from 29% in 2015 to 67% in 2016. And then it bumped from there to the 80s, the low to mid 80s. And it's kind of been hovering there ever since. What caused this massive spike in making fentanyl the primary reason for the shift in these illicit deaths from something else to fentanyl?
Let me start by gently pushing back on primary reason.
Okay.
In part because the point I just wanted to remind people of is that these are polydrug poisonings. People almost invariably have multiple drugs in their system. It's impossible to tease apart which one is contributing to
like your example
cause
earlier,
of death.
if someone has some alcohol, then
Yeah.
they have some fentanyl, then they take some cocaine, then they go back to fentanyl.
Exactly.
What killed them?
Exactly.
Okay.
So there are also market fluctuations, and within that profile of drugs that are used and that are detected on autopsy, there are known to be big changes over time. Benzodiazepines, even in the last 6 years, benzodiazepines have gone from being relatively like single digits in terms of prevalence to over 50%. Among decedents. So these changes are not uncommon. The change relating to fentanyl is principally related to volume, and the fact that you can conceal fentanyl and carfentanil, an even more potent synthetic opioid, are infinitesimally smaller in terms of an individual dose than the required amount of heroin. So from a trafficking perspective,
so this is an economics thing.
It's
almost.
economics and risk.
Right.
Yep. And it has some relevance to where we are. As of 2 weeks ago, decriminalizing drugs in BC, where possession of up to 2.5 grams is permitted. That gram limit is it's hard to understand when we consider for a second that 2.5 grams of fentanyl or 2.5 grams of carfentanil would take out all the occupants of a building this size, high-rise office tower,
Hundreds
downtown,
of people working here.
Hundreds of people. So the gram limits in this context
You must
make
have been
very
shaking
little.
your head when you heard this policy come out.
It's
There's 2.5 grams. I mean, if I'm a drug dealer and I'm walking around with 2 grams of fentanyl, I must be like just laughing right now because I don't have to worry about any cops shaking me down for. Versus,
these are imagine the difficult spot that the police and other first responders are put in, but
Sure.
but police in particular, because now they've got this essentially in their face.
Yeah.
Their 2.5 grams of fentanyl is a fairly plentiful supply.
Yeah.
If you're a dealer.
Yeah.
So now police are having to essentially watch as an extremely dangerous source of drugs in the communities that they're serving is now legal for possession and legal for trafficking.
Okay, so Julian, whether it's fentanyl or it's carfentanil or this latest one you mentioned, what was it you said went from single digits to double digits?
That's good old benzodiazepines.
Benzodiazepine.
Yeah.
I want to just speak to total number of deaths by illicit drugs, regardless of what actually caused it. And it sounds like what you're suggesting is it's probably a multitude of drugs in these poor people's lives that take them for their lives. This is the BC Coroner's Service, and I look at the graph. It's amazing. Like I look at 2011 to 2021 or 22, and it's just unbelievable. I mean, like at the end of 2012, for the listeners to get a context, the total number of deaths by illicit drugs in British Columbia was 270. And we're not talking about 1912. We're talking about 2012. 10 years ago, 270 people died of illicit drugs. In the month of January of 2022, 213 people died. Almost the same number in one month that happened in an entire year 10 years ago. We've gone from 270, 334, 369, 529, then again 2016, spikes to 1,000, 1,500, 1,000, 1,700. In the last 2 years, it's bordering around 2,300 people. I don't even know what that is on a per day basis, but it's got to be, what is the math on that thing? Someone got a calculator? What's 2,300 divided by 365? Yeah. 6.3. 6.3 people dying every single day. I mean, this is unbelievable.
Yeah.
I mean, this. I'm going to go divert for a second. During COVID, we had such a focus on like masks and vaccines and keeping people safe, and these deaths are far higher than any COVID deaths occurred, and it makes me kind of sad because we don't really treat all lives equally. You know, like if we had the same amount of effort and energy by our political leaders to tackle this problem as we did on COVID, I mean, even a tenth of what we spent on COVID in money and time and effort, I think these numbers would be way down. But these are just numbers that keep seeming to. I mean, maybe we've plateaued here, but at 2,300 a year, that's a lot of people dying in British Columbia.
Yeah, you're right that our leaders, and I don't think this is the way most people in BC feel, but our leaders are treating these lives as being of lesser value, and even with a degree of contempt.
I mean, you just look at the stats. I mean, if I was Prime Minister, Premier, Mayor, and I looked at these numbers, I'd be like, clearly whatever we were doing or have been doing isn't working.
Yeah. By the way, it's the premier of those different levels of government that has the most opportunity to make a difference here, or makes the biggest difference, because of the way our resources are allocated governmentally and where the budgets are. In terms of cause, so we pivoted from the idea that the ultimate cause has something to do with the external supply of drugs, and that it may be something closer to home. Mm-hmm. Toward that, when people have survived poisonings and been asked about their state of mind at the time, published research on this finds that about half were suicidal at the time of their non-fatal poisoning, the first one, and that the likelihood of experiencing suicidal thoughts along with the poisoning, non-fatal poisoning, goes up the more that you've survived. Wow. BC also has the largest increase in suicide over this period of time. So your earlier comment about suffering, some economists looking at this phenomenon in North America, looking at where there are concentrations of deaths due to drugs and deaths due to suicide, have coined the term deaths of despair. And they chose that term because where they're seeing evidence of concentrations of these forms of death, there's also evidence of loss of hope, loss of opportunity. And so that's an important part of what we need to consider as a cause here. Mm-hmm. Is a lot of these things they amplify pre-existing factors in BC, but those trends that you referred to start in the aftermath of the last global economic downturn.
Sure.
Where we just sort of see an amplification of things. Since that time, I mean, remember before COVID, headline news was, if I'm not mistaken, Indigenous people across the country blocking railways in solidarity with British Columbia First Nations people, mm-hmm. because we're the last place on the planet not to have formally resolved relations between colonized and colonizing peoples. That was pre-COVID. That didn't get better during COVID. It only got worse.
Right.
We have also continuing wealth inequality and more despair among young people who move here. So where else do we see this? During the same period of time that deaths are going up, we have a more than doubling of the numbers of British Columbians that are involuntarily admitted to hospital. We have a rise in the use of prisons from about 45% of the people detained having addictions and other forms of mental illness to about 75%. Wow. So when Premier Eby and others stand up and sort of equivocate on, are we in favor of involuntarily helping people under some circumstances? The horse is out of the barn. You're already involuntarily intervening by hospitalizing people against their will, by putting people in jail. They happen to be involuntary interventions that don't result in any long-term benefit.
Right.
But we're way past the point of, are we involuntarily intervening? I'm back to what we need to focus on, which is this state of despair. And we can modify the conditions that people are living in ways that make a difference. Other places have shown it. Alberta, right next door, is undergoing a sea change. inspired by what Portugal did, but doing it in a way that makes sense in Alberta. And thankfully, they're 3 years in. A lot of that was planning and organizing. Now that they have resources in place, their numbers over the last 6 months of poisonings, of first responder incidents, and of deaths have started to go down.
Oh.
We're not seeing anything like that in BC.
Yeah, no, we aren't. No, definitely not. Okay, well, I want to go back to your comment a moment ago about institutionalizing people. You worked at Coquitlam's Riverview Hospital, and I think maybe you may change my mind here, but I've always kind of thought, well, maybe one of the problems we have is that we aren't taking these people and putting them into sort of safe, institutionalized environments where they can get better and then hopefully at some point integrated back into society. Or for some of those who are really at the sort of edges, just keeping them in a place in perpetuity. At least they're not on the street, and they're costing us $55,000 a year anyways. Are you in favor of opening up Riverview style hospitals, but in a more modern, compassionate way that you wouldn't have had? Like, I'm not talking about One Flew Over the Cuckoo's Nest kind of like 1970s style, but it's 2023. Open up some locations in not urban centers where the drug dealers can show up at their doorstep and get these people clean. Is that something you would be in favor of?
No.
Okay.
But here's why.
Yeah, explain why.
I was introduced to this field by several people working at Riverview, just sort of onboarding me, and one thing that I learned, and I've now had a chance to investigate myself over the years, is that we deinstitutionalized. Places all around the world agreed to do this. It's not unique to BC, but we all agreed that deinstitutionalization was the future because there was already compelling evidence that people had a greater chance of a higher quality of life and also of long-term recovery from severe mental illness when they were supported in community settings that kept intact as much as possible of their family, their community involvements, their vocational activities.
Right.
So, of course, there are supports that are needed for people depending upon the severity of their symptoms, the duration of their symptoms. But the bigger picture was, and our slogan, by the way, those that will remember this, was closer to home. The government slogan, coincident with closing Riverview, was providing care closer to home. It summarized this knowledge that was present in the 70s and 80s. We didn't follow through. The VPD wrote a really impactful report, the first of 3, in I think it was 2006, called Lost in Transition, where they were describing the fact that we said we were going to do this, we didn't do it, and now police are increasingly involved in responding to what look like unmet mental illness related problems that they're not equipped for. That was 12 years ago. It's only gotten worse.
Right.
So we've now had the opportunity. People might say, well, okay, well, that was the 70s and 80s. The population's different now. Actually, no, it's not meaningfully. We've had the opportunity, my team and teams in 4 other Canadian cities, through a project known as At Home Chez Soi. In Vancouver, we identified hundreds of people living rough, serious mental illnesses and addictions, randomly assigned them to different conditions. The one that has shown by far the greatest promise is providing people with choices of housing that's dispersed in communities. So they have opportunities to not only select from, usually for research purposes, we'd aim to make it 3 choices at any given time. But they get to choose is the important thing, and then they get to become members of diverse buildings. So if anyone was, I think as a thought experiment, listeners can consider, if there are 2 buildings, if you're homeless, there are 2 buildings. One is filled with a diverse mix of people, young people, old people, kids, etc. The other building is entirely made up of people who have been recently homeless and who have mental illnesses and addictions. And which building would you want to move in?
Right, sure.
And if your choice is the diverse building, why do you think someone with a mental illness would choose differently?
Yeah.
Right? They don't.
Right.
They don't. And research shows they overwhelmingly choose independent, air quotes, normal accommodations.
Right.
Our research shows that not only will people choose that, but the results for them and for communities are vastly better when
there's
they're
a higher
given that
probability of
choice.
them coming out on top by going into that environment.
First year. So remember I mentioned earlier that we had asked people for their consent to access administrative records. Through that permission, by virtue of their permission, we could look at emergency department contacts, crime. People given choices of housing had 71% fewer criminal convictions and more than 50% fewer medical emergencies, crises, than people who were randomly assigned to usual care, which, by the way, is not nothing. It's what, the premier and the mayor and others are saying, vote for us, we got this, right? We've been hearing that for 15 years. Like goes back to Gregor Robertson.
Yeah, sure.
So it turns out, no, they don't got this. But something else that's important, when we do help people, we tend to focus on grouping them together in single buildings, something Premier Eby has really rammed through, actually, in a number of communities, are development applications for buildings of up to 100 people in otherwise established residential neighborhoods where there are no mental health supports. And I'm saying this having read the successful bid to be the operator. No mental health supports, a consumption site in the building, otherwise residential spot. You're basically setting people up to live lives of addiction and maybe PlayStation. That's it.
Wow.
Right? We were able, as part of our experimental work, to see what happens when you don't do that, but group people all together. So 107 people all living in a building with a fairly rich array of supports on site. It was the same complement of resources that we used on an itinerant basis to help people in the scattered site conditions where they chose. So same mix of professionals, same budget, but not the same outcomes. The level of crime and the level of medical emergencies among people living all together was no different than the levels among people who remained homeless. And the answer is culture. The answer is social mobility. The answer is people live when they moved into scattered housing, they told us that they were starting to feel like, air quotes, normal people.
Right.
Like
this is
I never thought I'd be in a close relationship. Right. I didn't think I'd be able to reconnect with my kid.
Yeah.
By the way, let me emphasize, fully a quarter of the people who meet these criteria, hardest to house, serious mental illness, et cetera, severe addictions, a quarter have kids under age 19 that they're clearly not living with. When given the opportunity to reconnect, that is invariably the most powerful motivator in their lives, is the prospect that they can see themselves improving enough in their well-being, in their sense of self-confidence, self-control, dignity, that they are now feeling like they could be a positive, because they don't want to reconnect just to be, say hi. They want to reconnect and be a positive presence. And they start to see this come into view. It's like, it's miraculous, right?
Yeah, that is pretty
we're not giving people those opportunities.
Yeah. Wow. Well, I can see that. And it's interesting. I got a chance to watch Vancouvers Dying. You got interviewed by Aaron Gunn. He came onto our podcast recently. And they had that one young fellow who was, talked about his story of going into one of these central, it was like one of these hotels, I guess, that the city bought, or a housing project where, like, literally you're just being, it's like, it seems to me like there's no difference in being homeless, except that you don't have to worry about getting rained on. You've got it's almost worse in a way, because they're just there being picked off as victims by these drug pushers, and they have nowhere to go.
Yeah, I mean, some colleagues did a study of looking at the sort of untreated medical illnesses, and they had the budget to do imaging, like medical imaging of people. They found untreated bullet wounds, with people living with shrapnel.
That's amazing.
And the level of neglect. There are many people, especially younger people, who are experiencing homelessness. It's a huge problem, by the way, that implicates our foster care system, because a significant proportion. It's going to be 55,000 people or something like that. So like something less than 1%, like a tiny amount less than 1% of the population who would ever encounter foster care. But it's close to 30% of people who are living homeless with serious mental illnesses and addictions. So they're out there. They've got no one in their corner, and once you hit that that magic cutoff of young adulthood, you're on your own, and you look at where people who have no money are living. You see urban places like the downtown Eastside. Young people do not want to be part of that scene, and it is, as you said, unsafe. But it's also unsafe for many older adults down there due to their mental illnesses, and women who are a minority of those living on the streets and even in SROs are peculiarly vulnerable to predation, sexual predation, sex work predation, and other forms of coercion that ought some time ago to have sort of shocked us into action. And maybe I think we're getting closer, by the way, so I don't mean to sound overly pessimistic, but it was 2006 for people who've been following this for a while, when the Senate of Canada, led by Mike Kirby, undertook a cross-Canada careful review, thousands of testimonies relating to mental illness and addiction. And they concluded two things that just stick with me indelibly that we've got to remember. One is we need to institute across the country community-based and recovery-oriented services. We need, and both are important, and they go together. I touched on it earlier. Being in community and having those ties and connections is a big part of what makes recovery a prospect and a viable possibility. So those two things go together. But the second thing I want to emphasize is that when they came to, okay, so what are we going to ask for after all this work? They asked for $1 billion. They didn't get $1 billion, but they asked for $1 billion. The important part of this is $500 million of it was purely for housing. Not particular types of housing, not housing for people with mental illnesses, right, or anything like that, simply housing, because we had allowed mental illness and addiction to become such a powerful determinant of homelessness in our country. That has not gotten better.
Well, that's a really well said and good point. Safe supply, do you believe in it?
As a marketing term, yeah. If you're asking, as a shareholder in pharmaceuticals, yeah, I'm for it. I mean, it's a genius, right? Here we are, Andrew. Let's imagine we're in some corner office. We're 10 years back. We're sort of agitating. We're being dragged into court, sued over Oxy, right? All that marketing we did, right? We knew it was dangerous, but we got caught. Now we're our heads are spinning. Where are we going to end up? But wait, there's good news. There are some guys out in BC who figured out a way to take not only opioids, but stimulants like cocaine and meth and other things that we're not really even able to sell very much. And they have found a way to get the government to pay for it. And no, it gets better. We're calling it safe supply because our play here is we are better positioned to be drug dealers than cartels. And it gets even better. Our customers are addicted to drugs, right? So they're going to use lots and for as long as possible. So, things are looking up. And that's what's happened. The leaders in BC, and again, this is only in BC. Safe supply is a term that was created here, has been promoted by people who do research here. No evidence that it actually results in any improvement. And if
there's any evidence, it's not working. Like if there's any evidence, this is the evidence that it doesn't work. What is that number again? 2,272 deaths last year. The year before, 2,306. This just came out. You got a piece there. I'm sure you've read this news in the Kelowna Now, that now a company called Adastra Holdings is been given authority by the Health Canada to possess, produce, and sell cocaine.
Yeah,
this is crazy.
Yeah, we need a bit more detail on what exactly they're supposed to do with their up to 250 grams, or I forget what it is, a quarter of a kilo they can have.
But Julian, isn't this kind of nuts?
Well, it's following an established pattern, I'm afraid. So let me give a shout out to a source of information that people might be interested in. The Stanford Lancet Commission in 2022 released their reports, a 50-page document, and analyzing the North American opioid crisis. So they focus on Canada and the U.S. The first key message they emphasize is that the problem is linked to profit taking among people in the health and regulatory space, going back and forth. They say, but they list a lot of things that we ought to be doing more of, can be doing more of, based on evidence that would make a positive difference in people's lives. They add, by the way, there are two things that governments ought to be wary of. The word they use is skeptical. One of them is the idea that it would be helpful to provide drugs dispensed from vending machines. Don't do that. The second thing they say is, don't try to grow a pharmaceutical supply of drugs with the intention of trying to displace the illicit supply. Now, those two things, vending machines and a pharmaceutical supply, are our number 1 and 2 play in BC.
Right.
And we're doing exactly the things they say not to do. How is that possible? Part of the explanation is profit seeking. It gets back to their first key message. Mm-hmm. Our former provincial health officer, Perry Kendall, owns a heroin company. He co-owns it with the director of population health at UBC, who is also the chief scientific director of the Michael Smith Foundation. So people who have the ability to influence research and who've been giving advice to government co-own a heroin company. The former
incredible
deputy provincial health officer, a fellow named Mark Tyndall, owns a vending machine company.
Yeah, he was one of my first guests on Coastal Front about 3 years ago.
He's done great work in the area of infectious diseases. Mark, that's his specialty. Yeah. Mark has contributed, and as did others. As did others to, an incredibly important chapter in BC health history, which was our role in helping to advance the fight against AIDS. Mm-hmm. But in this area, when he
was a guest on the show, he was talking about bringing out the first
vending
machine. He hadn't done it yet.
Yeah. So, it
seemed a bit odd to me, but
well, for people working in addiction who have known for some time that what makes the biggest difference are interpersonal relationships.
Yeah.
The quality and kind of interpersonal relationships, opportunities to have a relationship with an employer, with coworkers, with fellow residents in a building, all these sorts of things. And the idea that for people who are markedly isolated socially, that our next step is going to be to remove an opportunity for human contact, even a pharmacist, and replace it with a machine is just crazy on the face of it. Anyway, the Stanford Lancet Commission agreed. But the point I'm getting at with respect to the cocaine license is that we have already established a norm that profiting from the misery that we see around us is okay. In fact, it's to be rewarded. It's being framed somehow as innovation. We're not doing this in order to generate it's not out of self-interest. We're doing this altruistically. It's hard to square that with evidence, though.
Yeah. Okay, Julian, well, we've gone through the stats. Clearly, whatever government policy has been, it's not working. And we have set a new norm that's kind of, quite candidly, making me feel a bit worried about where we're going from here, because this shouldn't be the norm. To wrap up what you've said, we've really almost had government and profiteers go from making the distribution of illicit drugs a illegal activity to almost a legal activity with an opportunity to make a profit off of it. This latest one is this idea that somebody in BC has the ability to now produce, and sell cocaine. It just blows my mind. We did talk earlier about what happened in Portugal, but Portugal is a different country, different situation. You're here in BC, I'm here in BC. Downtown Eastside is the epicenter of this misery for these people. And it's not just there, as you highlighted. To kind of put a bow on this and put a positive note, because it's quite honestly, it's a bit depressing talking about this and realizing how bad it is. And I appreciate having people like you in the trenches every day doing work on this stuff. If someone like David Eby, Ken Sim, or Justin Trudeau were listening to this podcast today, what would your advice be to them? How would you tell them, like, maybe you have talked to these people, but like, what would you say to them? Like, guys, this is what we need to do here in BC. Here's some easy, low-hanging fruit right now that can change this around, similar to what you highlighted is happening in Alberta right now.
Yeah. I'll start with a simple metaphor. My metaphor is meant to be kind of what can we achieve through harm reduction, and what do we need other things for? Because overwhelmingly, what we're doing right now is more closely related to harm reduction strategies. So if somebody is wanting to just change how they feel inside their body, become a lot fitter, make a big difference, they might then find themselves, in the grocery store, and they're going down there the chip aisle, and normally they'd stop for some Doritos and maybe some Cokes over there, but they decide no, I'm not going to do that. Right? Okay, that's harm reduction. Right. You're not making those. You're going to let that go because that's
good analogy that we can relate to.
Yeah, we can all relate to this. But there's no amount of not buying Doritos that's going to transform your body. Right. You need a vision of what you're trying to achieve, and you need to work. Right. That's what we're missing in this context. We know things we're against. We're against people dying on the sidewalk, so everybody has Narcan. We're against people freezing to death outside, so we have emergency cold weather shelters. Okay, we all know what we're against. Mm-hmm. What are we for?
Yes.
What is the long-term vision for these people?
Yeah.
This is what we need.
Mm-hmm.
So this is what the Out of the Shadows at Last report from all those years ago, this is what it meant when it used the term recovery-oriented, community-based recovery-oriented. There has to be a vision of being in a better place, of greater wellness. So we need in our communities to be having in BC conversations about what vision do we have for people that are currently suffering and at risk of death. And one place we can start, because of where we are in BC and our particular social obligations, we could start by thinking about Indigenous communities.
Okay.
And the outstanding burden of reconciling. Indigenous communities are asking for a number of things and have for many years, but they include the means of re-strengthening their communities. I think we need to see that opportunity as completely related to the fact that those who are at risk of dying are disproportionately Indigenous. And by putting that on the table as part of our long-term strategy to address addiction, we actually are backing a winner. It's a multiple word score because it's going to help us in other respects too. But we also need to apply that thinking to other communities. Now, I can be more concrete than that. We've, based on research through randomized trials, we've shown that a lot of ways of helping people that are meaningful and long-term are viable in Canada and in BC in particular. So unlike our current approach where we funnel all of the housing dollars through BC Housing develops their congregate buildings or contracts with people to do it, we need to be thinking about this unpaid debt to people with mental illness following deinstitutionalization, and turn to landlords in the private sector. We need to be securing a large portfolio of long-term housing that is scattered and dispersed. We need to be similarly in those communities working with employers and talking to them about decades-long, well-established models of supported employment. The province partnering with employers around not explaining these models, but also providing the resources to make that work. It has much more to do with engaging the private sector as an important ally. And by the way, for most of us, the inclusion of more and more public services in our lives as something we need is not the way we think about wellness, right? We want less.
Yeah.
And that's what I'm talking about, is calling more on the organic and health giving aspects of our communities. So I'm talking employers and landlords right now, and develop the capacity to provide supports for people that are dispersed around communities in areas where we know there are high concentrations of folks living in need. A final thing I'll mention is related to business intelligence. We know a lot of the stats that I've referred to are knowable and in the public domain because for the last 20 years, until recently, BC had been making good use of multi-ministry information about people spiraling between multiple sectors, hospitals, jails, the streets. And among other things, we've been able to identify where are the concentrations at the neighborhood level of people around BC who are experiencing these syndromes. And we need to be using that kind of information not only to plan where we're making a difference, where we're investing. It can't all be in the downtown Eastside. That's going to come years too late for many people. So using it to not only plan where we put investments, but also using the same information to track how those investments are paying off. Are we getting the same impact and benefit that we've been shown is achievable in randomized trials? We know it's achievable. So are we replicating it? And if we're not, let's just take a clear-eyed view. And it's not about beating anybody up. It's about how can we get better? Yeah. Some will be better, some will be not so good. How can we learn from the good ones, make the other ones better? So this is a vision.
Seems such common sense.
You'd think. I thought I was on safe footing presenting this to EB's government, we were poised at the time. I'd been leading this work, this interministry work, by that time for a while. We had already renewed with the contributing ministries for another round of work that was based on a COVID-related project that we had funded. And we were in the process of updating the data. I made this presentation, and 1 week afterward, we got a letter at SFU saying, thanks for the last 20 years. Please arrange to destroy the data by the end of the month, which was 3 weeks notice.
Destroy the data?
Destroy the whole thing. Destroy everything.
Like proverbial shred what you got?
Yeah. Destroy. And part of the letter is this is by the way, the letter's online. You can go to my website, Somers Psych. But it's other people have posted it too. And they said, and also make sure you sanitize the drives. So this was.
You got to be kidding me.
This is it's in the public domain. And as I said, we were already in the process of renewing. The Ministry of Health had already renewed the information sharing agreement for another year in order to accommodate this work that we had agreed upon. And the best explanation I have is it's linked to my presentation. And part of the explanation, I didn't find this part out until many months later. At the time I made my presentation, the government had already committed to implementing single buildings with consumption sites as part of its solution. I had shown them from randomized trial evidence that that's not going to result in wins. So I didn't know I was shooting myself in the foot. Right. But
they'd already made their decision. The referee had already made their call.
Yeah.
Wow. You mentioned Somers, your website, Somers Psych.
Yep.
You also have Somers Research Group. Can you talk a little bit about that and to kind of wrapping this up? Like if people really like this conversation like I have, this has been fantastic. How can they continue to follow your work?
So thanks. I really appreciate that, Andrew. Well, at this point, it's so we are doing research. Our group is very involved in a number of projects. I think where most people can make a difference is they'll start simple on the website. You can go to a tab. It's get in touch, lend your voice. And hopefully many people have told us that they find it's pretty easy to navigate, but it's essentially an easy way to send a letter to elected officials You can select them from a drop down, and it's not asking people to sign up for anything too specific or anything like that. It's telling people, it's giving people an opportunity to send a letter that says, we don't think what the current approach is working. We want there to be more of a conversation about additional options, because that's I think what's needed. I think it would be premature of someone like me to come in here and say these are exactly the things that are needed. There's a point at which we all need, as the Portuguese did, we all need to come together. We all need to come together and have the conversation about, where do we want to go? What's the vision for the next generation?
Right.
Or however expansively we can think. If you want to think about grandkids and great-grandkids, fill your boots.
Going back
think
to
about
your
the future
philosophy of, like, we know what we don't want, but what we haven't had as a genuine conversation about where we want to get to.
Yeah. So our leaders have backed away from that. There's no sense whatsoever.
We need some vision.
We need vision. And it's not, and at this point, it's not going to come from our leaders, but perhaps it shouldn't. Perhaps it's better, it's more likely to be effective if we all recognize, as many of us as possible, that we need to have conversations with each other, and conversations at the community level that then get networked. And if we do that, it's really nothing short of talking about what we want, how we want to redefine our social contract.
Yeah, that's well said. I like it. Julian Somers, distinguished professor at SFU and director of the Center for Applied Research in Mental Health and Addiction. Thank you for being on Coastal Front today. It's been a great conversation, and I wish you much success in going around and talking to the community and spreading your gospel, because this is really well said. It's made me rethink some of my own prejudices or thoughts that I had before this conversation. So thanks for being on today.
It's always great talking to you, man. I'll look forward to next time.
Okay. Thanks, Julian.